First, thank you for the invitation to come. Really looking forward to speak today about more. So we start with the clinical aspects of CSF dynamics, and I wanted to address three aspects actually. How is possible to visualize movement of CSF tracers, and also to assess CSF flow in the visual CSF spaces of the brain, and how is a CSF tracer moving within the extravascular compartment of the brain, and then third, looking at the neurobiology of the extravascular space of the CNS. So I thought we start with the clinical aspect, and then we today in this talk look on idiopathic normal pressure hydrocephalus. This disease is quite interesting from several aspects because it is a neurodegenerative disease, and it has several similarities with Alzheimer's disease. So it's, in a way, in several respects, it's a model of Alzheimer's disease. Of course, not in all aspects, but what we see in these patients is accumulation of amyloid and tau within the brain, in the extravascular space of the brain of these patients. So they share several similarities, but it's also for sure different. And this disease is characterized by CSF circulation disturbance, and it's also characterized by abnormal pulsatile pressure within at least those patients that respond to shunt surgery. CSF diversion surgery is the treatment, the only treatment in these patients, and it can improve symptoms. Not cure patients, but improve symptoms, and at least for some time. So looking after shunt surgery, then we see that this is a way of, in a way, assessing the clinical improvement in the patients. And in those responders, we see that over years, the response is being reduced. So this is how it may be in a patient. These patients, they have gait disturbance, they have incontinence, they have cognitive failure, and then they can have improvement by CSF diversion. So, of course, in that respect, it's different from Alzheimer's, but still several similar aspects with Alzheimer's. So, therefore, this is also one aspect why it's interesting to look at this group of patients. So, to begin with first, to look at CSF flow in CSF spaces and movement of tracer, particularly addressing these normal pressure hydrocephalus. So what we have used is applying a CSF tracer in the spinal cord, and then we can look how this CSF tracer is moving to the CSF spaces and into the brain of the patients, and how this is occurring over time. So here we see the CSF tracer, and we also we can look how is the time for this. So these are the first 100 patients that we have applied MRI contrast agent intrathecal to the spinal compartment, and then we visually assess when the tracer is coming to the cranial-cervical junction, and we see it's occurring quite fast. So at the group level, and these are different kinds of patients, it's about a mean time of 20 minutes, then these tracers have moved from the lumbar region to the CCJ. And also a lot of variation, or at least some variation. We see that some individuals, it take longer time before this tracer is coming to the cranial compartment. So how is this CSF tracer moving within the CSF spaces? And this is T1 sequences of MRI, and then we can see the tracer as white color, and we see this is a reference patient, and then we can see how this comes up, distributes in the subarachnoid spaces, and then in a way we can have an impression that actually the brain is in a way lighting up, so to say. This is different in normal pressure hydrocephalus. Then the CSF tracer has another pattern. So it's moving from the spinal compartment to the fourth ventricle and into the third ventricle and to the lateral ventricle. So the CSF movement is more rapid right into the ventricles. Of course, we are looking at the CSF tracer. It's this godobetrol, the MRI contrast agent, has about 600 Dalton molecular size. So this is not movement of water, it's movement of a CSF tracer. And we can see how this has a different pattern in iNPH patients. Another aspect is that in this, call it dementia disease, then the movement of CSF tracer is delayed in the CSF spaces. So this is all the visual CSF spaces that we can see. And at the cranial cervical junction, we can see in normal pressure hydrocephalus, then the CSF tracer is arriving at a later speed, but the clearance, this is after 24 hours, then the clearance of tracer is delayed. And this is the same in the pontine cistern. Again, later in iNPH, cleared at lower rate or more slowly in iNPH. Sylvian fissure, it's the same, precentral sulcus, but regarding the ventricles, then it's different because the CSF tracer is moving rapidly into the ventricles. We see that the clearance is very much delayed from fourth, third lateral ventricles in these patients. So movement of CSF tracer is for sure different in this group of patients. From MRI, looking at flare sequences, a typical sign in these patients is this hyperintense area in the periventricular space of these patients. So this periventricular lucency is quite typical. What we see applying this CSF tracer is that this CSF tracer is being transported from the ventricles into the brain from the periventricular side. And the degree of this transport is related to the grading of the lucency that we see on the other images. So there is transependymal transport of CSF tracer in these patients. So what we are looking at then is that we see that the tracer is going the opposite direction. As you know, normally, at least in reference patients, it's going from the ventricles and out. So this aspect we also have addressed from another perspective, looking at CSF flow using phase contrast MRI. And then we have, and this work it's a collaboration work together with the people here partly at Simula and at the Department of Mathematics. And then we look at these spaces. It's basically the aqueduct and the cranial cervical junction. And then it's possible, based on the phase contrast images, to look at the individual pixels. Cranial cervical junction, reference area, aqueduct, reference area. And as you know, this fluid movement is bidirectional in these patients. So it's going up, and it's going in both directions. Again, cranial cervical junction, and it's the same in the aqueduct. So this is something you're familiar with. So here we are looking at the CSF flow at the pixel basis. This is a reference area, and this is in the CCJ and in the aqueduct. And then looking at the mean velocity. And for sure, it's variance, it's difference between individuals. It's variation between individuals. And then looking at how this is during the cardiac cycle, we see this is healthy volunteers, or we could also see healthy mathematicians, perhaps. And these are patients. And there are different things we can look at. So this is the net, how we compute the net flow in these patients. And again, we can see that there is variation. And what has surprised us is that the net flow in the cranial cervical junction is upward, is in cranial direction. In the aqueduct, in many patients, it's in the cranial direction. And the volumes is very much higher than we have used to think about. In the volunteers, then again, in the CCJ, it's up, and in the aqueduct, it's from the third to the fourth ventricle. And we also looked at this in patients with subarachnoid hemorrhage. Subarachnoid hemorrhage is one kind of disease that causes very marked changes in the CSF movement. And again, looking at the individual pixels of in this case, the aqueduct, then we see the reference region. It's some noise, different from patients, and then we look at the CSF flow in the aqueduct. And then computing what's happening over 24 hours periods. Then again we see this is a rather small cohort, but what's interesting, it's different. It's quite a large difference in these patients. So then I would say that these values are not, in a way, the correct values. What is the volume moving within the aqueduct? Because what we have looked at here is calculations based on what's happening during the cardiac cycle. And for sure, there are other aspects that is determining this movement of fluid. And in one paper that is coming very soon, then people here at Simula and ourselves, we have then modeled how the difference is during the cardiac cycle and during the respiration. So the main message is that during respiration, the volume of flow is very much larger than during the cardiac cycle itself. So what I would say is that there are different aspects that determine the volume of CSF flow in these spaces, both the cardiac and even more important the importance of respiration. So, looking at CSF flow in the visual CSF spaces, what can this learn also, or in a way tell us about what we see clinically? And in these patients, the ventricles, the space, the CSF spaces, they are changed. So one typical aspect of ventricles in these patients is the disproportional enlargement of the subarachnoid spaces. So the sylvian fissure is increased. We see here flattening over the convexity, and typically the space or the, this angle is different. So what we think is that the redistribution of CSF flow and thereby the pressure gradients are what is actually explaining what we see in the ventricles of these spaces. So in this particular group of patients, normal pressure hydrocephalus, it seems to be some kind of hindrance or a blockade on more the superficial side of the brain, while the CSF is moving more into the ventricle and then out in the parenchyma. Others have looked at this as well and see that this pressure gradient is more distributed upward. Okay, so then we are moving on to looking at movement of CSF tracer within the central nervous system. So that's another aspect of this. And for sure, what was inspiring us and many other people throughout the world is this description of this glymphatic system from 2012 that I'm sure you all have heard about. And basically what this is a description. It's based on rodent studies, basically mice, that there is free communication of CSF from CSF or the subarachnoid spaces via the perivascular spaces and also CSF into the interstitium. So there's free communication. What we have in a way previously thought was that there is a difference, so to say, between the interstitial fluid and the CSF fluid itself. What this has learned us is that this communication is direct from the CSF spaces. A lot of discussion whether this movement along vessels and also in the interstitium, the forces behind this, whether it's convective or diffusion, and the original theory is that movement is by convective forces. And I think we are going to hear more about that during the meeting, but the original concept is about arterial pulsations as driving forces and behind this convective flow. So this transport of fluid and also solutes is then aquaporin dependent, aquaporin 4, that is enriched at the astrocytic end fit of the glia cells. So this is then a pathway for clearance of metabolites from the brain. And in a way, adding a new aspect, so to say, to the role of CSF. So again, this is aquaporin dependent in mice. Without aquaporin, then the distribution of this CSF tracer is very much reduced. And back to this neurodegeneration, amyloid accumulation, it's important because evidence has also been then given that this clearance of soluble amyloid is reduced when also aquaporin is reduced. So it depends on aquaporin. So what we have done then is to very much inspired by the glymphatic concept, we have then administered this MRI contrast agent and then looked at how this tracer is distributed within the CNS. So then here the tracer within the CSF spaces has been removed, and we can look at how the CSF tracer is moving from outside the brain, centripetal, into the brain. And these are 1 to 2 hours after injection, and then we see this very high increased CSF tracer enhancement after 24 hours. So, and it's quite interesting to see how this is similar in this rodent model and the humans. This is CSF tracer from this 2012 paper, and we can see how the CSF tracer is from the cortical surface entering into the brain, and it's similar that we see in the human. And we should note that the highest appearance is along the big vessels, along the medial cerebral artery, anterior cerebral artery, posterior cerebral artery. So this is quite evident. And of course, there is a safety aspect to this, giving MRI contrast agent to a patient. Then there is a big discussion of retention. So we also have MRIs at a later time point. We haven't seen any evidence of retention in these patients. So after 48 hours, then very much of this tracer has been removed. So again, the brain is pulsatile. It's moving. Something all of us operating on the brain is used to see. No response. Okay. So we have some evidence that this pulsatile, the role of arteries, the pulsations, simply the distribution of the CSF tracer along the vessels indicate at least that pulsations and artery pulsations are important. So this is very typical. The very early signs of tracer is always along the vessels, as we can see here in the sylvian fissure. So what we see is that CSF tracer is distributing in the entire brain, all regions that we have looked at using free surfer, and it's very typical that the peak is after 24 hours, and then the latest scan that we do is in the evening. So what's happening from the evening until the next morning, we don't know that. So it could be that the peak is at another time, but the shape of the curve it's quite similar for all the different regions. This is from the basal ganglia and the limbic system, and also gray matter, white matter. So this is different in some respects from the animal studies. It's very much slower process, and also in the animal studies it was more a cortical event that was studied. So what we see in humans is that this is affecting the entire brain. And we also can see that we have looked at the lymph nodes. We can see that the peak enhancement coincides in time within the brain and the extracranial lymph nodes. So we see the peak enhancement in the lymph nodes is also after 24 hours. I also would like to mention that this is also something that we see in the visual system of humans. So looking at the different parts of the visual system, the optic nerve and the chiasm, and we see that the CSF tracer is entering the entire optic or the visual system of patients. So the CSF tracer in pre-chiasmatic cistern, then we can see the CSF tracer is entering this place, and looking at the optic nerve, even the retrobulbar location, and then we can look at the percentage change in signal units within the nerve, and again we see that this maximum is appearing at about 24 hours. So this is retrobulbar, mid part of optic nerve, and pre-chiasmatic, optic chiasm, optic tract, primary visual cortex. So it's quite interesting that when you give a molecule, a CSF tracer, to the CSF, lumbar puncture, then actually this is reaching the entire visual pathways in humans. So it's quite similar to what's happening within the brain. Okay, so what's happening in these normal pressure hydrocephalus patients? Some problems here. So as we talked about, this CSF tracer is entering into the ventricles. So one different aspect is that there is a higher transependymal transport of tracer in normal pressure hydrocephalus, and the entrance is even more intense in these patients. So they are different from reference patients in the way that the CSF tracer is enhancing more strongly in these patients. This is white matter, this is gray matter, and we see that the delay or the clearance phase is slowed down in normal pressure hydrocephalus. So both movement of tracer within the CSF spaces and also within the CNS is then delayed in these patients. So they have a slower clearance of molecules, these patients with normal pressure hydrocephalus. Again, I mentioned that it's interesting that this disease is a dementia disease, several similarities with Alzheimer's disease, and it's characterized by a cognitive decline. And this area of the brain is called the entorhinal cortex. It's a crucial area for cognitive function. And what we see is that the clearance of this CSF tracer is significantly reduced, both in the gray matter and the subcortical white matter of these patients. So we think that delay of clearance may be one mechanism why we see accumulation of toxic substances. So this is just to indicate that we see this in actually all the regions that we study, this delay of movement of CSF tracer. So then to close this down, I also would like to mention a few words about neurobiology of these perivascular spaces in the brain, because this region is in a way emerging as a very important place where events occur causing or being involved in this delayed movement of solutes. So from an anatomical point of view, so to say, the microvessels that penetrate the brain. You know that the capillaries of the brain is the big volume of the vasculature of the brain. So these capillaries, they are surrounded by the end fit of the astrocytes. The astrocytes is heavily enriched of this aquaporin 4, this water channel. And so this area where the basement membrane, so to say, the basement membrane, here we have the astrocytes, endothelial cells, pericytes, and this basement membrane is then a loose matrix where it's possible for solutes to move. So this region is important. It's a very important place for movement of solutes. So that's the reason why we have focused on this region. So what we have shown is that this aquaporin enrichment is less in the astrocytic end fit. So in normal pressure hydrocephalus, where we have a delay or a slowdown of movement of tracers, then we also see a loss of aquaporins. We think this is important, and at least it's telling perhaps some of the mechanism behind the slowdown of CSF tracer movement. And we also have looked at this anatomy of the basement membrane, and what we see is degeneration of this basement membrane in iNPH patients, and also changes in the pericytes that are important for the integrity of this, what also is called the neurovascular unit. So the process of the pericytes are degenerated in normal pressure hydrocephalus. So we think that understanding this area is very crucial to also understand this kind of disease, and for sure has relevance for dementia in general and Alzheimer's in particular. So I think we can agree that these new studies from the basic neurosciences, they has really inspired a change, and for sure has given us new insight also to the clinical aspect of CSF movement, and that we now see a paradigm shift in the understanding of CSF movement. Looking at the literature, this is really a field that is growing. It's happening a lot within this field now, and this, in a way, old concept of looking at CSF movement is for sure changing. From the clinical perspective, the situation that there is free access from the CSF to the entire CNS, it has really big implications, both regarding drug administration and also how we can treat these diseases. So that's one important lesson that we have learned, that molecules with certain properties, and then we have looked at this rather big molecule, but not macromolecule, 600 Dalton. It has actually the potential to reach the entire brain. So we are happy to collaborate with a lot of people. We are from the clinical at Oslo University Hospital and the University of Oslo. So to be here today with our collaborators, it's really fun. What we have very much has been very good and facilitated this research is this collaboration between mathematics, modeling, and the clinical aspect, and also the basic neurosciences regarding neurobiology. Yes, I think this was all I had to say. Perhaps I'm before schedule, but at least I've delivered what I thought about. So we have good time for discussion.
We have good time for discussion.
Yeah, I think it's a lot to discuss. Yeah.
And I'm absolutely sure that we will keep up during the day. Thank you very much for this fascinating overview.
Good.
Are there questions? I see Mark very good.
Yeah, that's terrific work. I've got a comment and a question. First comment is the flow of CSF around the vesicle was actually first demonstrated over 30 years ago. And what was new about the 2012 publications was that the suggestion that the fluid flows directly to the veins, a very one-way pathway, and that it's very specifically related to aquaporins. And there'll be a lot of discussion about that, I'm sure, during the meeting. It's controversial. I just point out that whole concept is not actually new.
Yes, I can I perfectly know that. So you have the Reynolds paper from '85, and that's. I think what has been important with the glymphatic is that it has created a lot of interest, and many people have got interested in this field, not least from the basic neurosciences. But you are perfectly correct. It's not a discovery in that sense of things that has not been looked at before. For sure, the literature is there, and you have completely right.
And my question is a clinical one. So, have you yet looked at correlation between your studies and clinical outcome from shunt to the point where you can use it as a diagnostic criterion or a criterion for surgery?
It's a good question. It's something that we are going to look at. We haven't done it so far. This is giving us information that I think we can use clinically. So I think it's quite interesting, and there are opportunities there. But I don't have an answer at this moment.
Are you using it clinically? I mean, does it influence what you do when you do these studies on patients?
You know, so far this is a research project. So it's implemented as research, and then we are not using, we are using our traditional assessment for patients. So at this moment, it's more on the thinking process, what we observe, so I think this kind of imaging is of interest that can have a clinical applicability. I think so.
Other questions? I think it was Roxana first.
Hi, Roxana Carrara from Southampton, UK. I've been following your work for a long time.
Yes.
My question, I mean, I will leave the controversies to later. Obviously, I'm very biased on our anatomical studies, and I firmly do not believe that the brain is a washing machine with CSF going in along arteries and out along veins. But anyway, the point is, the question I have for you is, you mentioned that in iNPH there is amyloid deposition. Do you know where the amyloid is deposited? Is it as plaques in the extracellular spaces? Is it as cerebral amyloid angiopathy? And if so, which type of vessels?
So we are talking about amyloid plaques and not the amyloid angiopathy in these patients. So it's similar to what you see in Alzheimer's. So it's extravascular, of course. You know, imaging or assessment is light microscopy that is used for this. So it's extravascular and it's amyloid plaques. And this has been studied in very many patients, particularly in Finland. They have been most important, and then Sweden, and to some extent here in Oslo.
So the white matter hyperintensities that are periventricular could have the same pathophysiology mechanism as the white matter hyperintensities just seen in Alzheimer's disease.
Could. We don't know.
Obviously, it's speculation.
Yes.
But how would you compare their location, their distribution? Because from my knowledge, from an anatomical point of view, in Alzheimer's disease, they are also periventricular.
Okay. So this particular aspect of Alzheimer's, that is, I haven't in-depth knowledge about that. So hyperintensity periventricular, whether it's similar mechanisms in iNPH and Alzheimer, only speculation from my point of view. But it's an important or interesting
we might
aspect.
use this group of patients to try and gain information for
sure.
For other.
Yeah.
Thanks. You said that in your iNPH patients you observed that there was a net cranial flow of CSF at the cervical spinal junction. What do you think that implies that there's fluid production in the spinal canal, if that's really true? Do you want to just comment on how you could actually have that flow and where you think that excess flow is coming from?
What is that there is some kind of obstruction to CSF movement on the surface of the brain. So we think that there is a redistribution into in a way, the pathway of resistance, so to say. Whether there is production of CSF in the spinal cord, yes, I think so. It's the movement of water is a very fast flux over the capillaries, and how this, for sure, there could be net production of CSF in the spinal cord, depending on the position of how we're working, laying, sitting, a number of factors that can impact this. At least with all its weaknesses, what from phase contrast MRI is in all a net movement upward in cranial direction. So it's in a way hard to explain this only from artifacts, that this systematic observation is only artifact-based because of weakness of MRI technology. That's I don't think so. But of course, and I think Oliver is going later that phase contrast has a lot of weaknesses, so there are a lot of questions regarding this technique.
Yes, maybe just a little question. We have discuss a lot about the accuracy of net flow measurement. A simple thing that it can explain that the net flow is a good way is, did you did the same acquisition in the same patients and volunteer, and found for these subjects that they can produce 30 liters per day. So
you said whether we did repeated
yes,
measurements
on the same subject.
Not in patients, but in volunteers. Then we have done repeated, and that was quite good. It's not perfect in any way, but repeatability was quite good in patients. Data on that. It has also been published. It's available in this neuroimage clinical paper.
Okay.
So it's possible to look at it. It's available.
And to have some so accurate measurement that in only one cardiac cycle then can produce a value of many liters per day?
Yes.
We can extrapolate from one cardiac cycle a result.
You know, a phase contrast study is for some minutes. I think it's 6 minutes or something. So it's average over that period, and of course to compute what's happening over 24 hours. Obviously, that has a lot of limitations, of course, but it's interesting because to have numbers how things could be over a long time, it's interesting to have some indication, but we wouldn't argue that these are accurate data. And as I also commented on, there are other forces or mechanisms involved, such as respiration, that heavily also impact CSF, the volume of CSF movement. In addition to what's happening during the cardiac cycle, that's of course only one aspect to this.
Thank you. The idea that there's an obstruction to flow of CSF that causes it to redistribute back into the ventricles is I think, black letter law at the moment. I mean, I don't think there's any real question of that. Do you know that your iNPH groups that have the tau proteins that you're talking about, the amyloid, are you not seeing a comorbidity rather than the cause and effect? I'm somewhat skeptical that this is going back to the treatment of Alzheimer's with shunts, that we're not seeing comorbidities in older people.
So I wouldn't say that this should be an argument for beginning treating Alzheimer's with shunts, because my intention was only to highlight that iNPH has several similarities with Alzheimer's, and in some respects it could be looked upon as a model of Alzheimer's, at least as a better model than some kind of animal or lower kind of animal study, so to say. It's one model that learns us something, but for sure the CSF circulation obviously different in iNPH and Alzheimer's. This shouldn't be an argument, again, thinking about treating Alzheimer's with shunt. I don't think so. And again, this distribution of amyloid in the Alzheimer versus NPH brain, much of this is histology. It's only the cortical, the superficial aspect, and then there are some PET, of course. So, but again, that is, I think it's an interesting idea that this deposition of amyloid is contributing to the neurodegeneration that we see in NPH. I think so.
It was very interesting to see this backflow you had in the iNPH patients. And then you related to a reduction of acroporin 4 expression later on. And this might be a very naive question, but for me, this glymphatics, so the perivascular spaces serving as a route for CSF or for lymphatics of the brain, was actually not 30 years ago, it was 1875 by his. So we've known that for a very long time.
It's always like that, you see.
Yeah.
There's always someone in the back.
No, but basically, so basically my question is, once we get into lymphatics, that's when the astrocytes are involved and the acroporin 4. So that is only, is my impression, in the parenchyma. So that's a wash through the parenchyma. So the data that you have, do they actually directly show whether we have glymphatics, or are you just showing that the sort of more macroscopic CSF flow in the perivascular spaces and the ventricles are disturbed? Because can you actually see whether you have less parenchymal wash in your iNPH?
So you know, we have used MRI. It has 1 millimeter. So we are not looking at glymphatic per se. We are looking at the CSF tracer moving in the extravascular space. So it cannot be used as a proof of glymphatic in that sense. But then you have to go into more, closer look, so to say. But anyway, we are looking at so this glymphatic is in a way creating a concept or a framework for explaining what we are looking at. But with our modality, MRI, and the resolution of MRI, then we can only try to explain what we see. So what we see is extravascular, sure, because of the blood-brain barrier. So this gadobutrol is not going into the vessels. So it's yeah.
Thank you.
But it's not a proof of glymphatic, of course not.
Following on the questions about the inflow at the junction, I'm curious about efflux. Where's that water coming back out of the skull? And also your observations of flow along the optic nerve. Where are tracers coming out?
Oh, that's a good question. At this moment, we think that the molecules are entering into the CSF, and that it's entering to the dural lymphatic system. So the observations are more supporting that kind of view. During the course, we speculated, could there be some kind of perivenous kind of movement of molecules? It doesn't seem like that is the case. So it's more looks like the tracer is from the CSF to the dural lymphatic system. And of course, you may have this transport along the cranial and the spinal nerves in the, along the roots. Looking at how the CSF tracer is moving, this can also be one part. I think that's your question is really addressing what is the big question now, so to say. Where is this passing out of the cranial compartment and the dura?
I have a question about your methods for your T1 mapping. So it looks to me like the edge of the tracer looks very distinct on those plots, especially the first time point. If you went back in your slides, you know, the
should I go back?
The contrast enhanced image, and I've struggled to sort of interpret those because they're using signal units, and I think obviously the imaging is really unique and it's been really helpful. I've looked at your paper 100 times in the last few years, as many of us have. And I'm thinking, can you put those into you know, real concentration units? And have you proven that it's obviously an asymptotic function, the relationship between contrast or signal units and the actual value of concentration. So I'm wondering if you're actually in your range of values where you have sensitivity to map the tracer that you're looking at, or are you sort of outside of that range where the asymptote has, you know, it's, I don't know if you're following.
This is very much a question of manpower, so to say. So we have T1 maps. And T1 maps, then we can get the absolute concentration. So we don't have data for that. But for sure it's an important question, and it's something that we are going to address. We are in a way at an early stage of addressing that question. Of course, the negative aspect of T1 maps is that the resolution is even lower. But that's the modality to assess the absolute concentration.
All right. So are you going to publish that soon?
We have just started.
That'd be great.
Looking at it, so I think it will take time. Yeah.
Thank you very much for the presentation. I really enjoy the work to see where this tracer goes. And but I was thinking, when you show the difference between iNPH and not iNPH, and you see that it goes into the ventricles, how do you, would you say, is it the bulk flow? I mean, we know that there is a much more mixing in hydrocephalus because of the big ventricles, and we have a hyperflow in the aqueduct, and is it a sign of that as well? And the end question would be, how do you interpret your data? Is it a sign of convection, as you said, with having a pressure bulk flow driving this into also the parenchyma, or is it a sign of much more mixing in the hydrocephalus?
Yeah, so you are addressing the mechanism behind how the tracer distribution is in the fourth ventricular aqueduct, and so then we need further collaboration with our friends here. We are going to more address this. Is it the mechanism? Is this mixing, or the forces? So I don't have an answer to give you now, but it's an important question, and it's something that we are going to address, because then we need modeling and we need other kinds of approaches to look at this. But it's an important question.
We have time for one final question, if there's any. If not, I suggest we thank Kristian again.
Yeah, thank you.